My name is Gautam Kulkarni. I'm a children's doctor, but I have a special interest in adolescent health. And adolescence, as we know, is the age range from about 10 till children turn 19. Now, the importance of this age group is that the problems that this group of children start experiencing is kind of fairly unique between the age between childhood and adulthood. And almost half the incidences of people who end up having um, mental health issues later on in adulthood, etc., will start during their adolescence years. Plus, also, you can develop habits and behaviors related to exercise or your diet or other aspects of your life, which can impact you for the rest of your life. So, just a quick brief on adolescence and how we actually take history through the adolescent age group. Just very briefly, this is the book I edited. I'm the editor of Recent Advances of Pediatrics, and the first three chapters are kind of focused on adolescent health. So often in complex patients, what we use in terms of a screening tool while taking notes is something called the S-Shades screening tool. So the S-Shade screening tool starts with strengths of the child, depending on, so this is something that we would ask older teenagers who may come up with complex health issues, maybe not simplistically, something like a child who's coming in for an allergy consultation, etc. But something that's more complex, we'd use the S-Shapes tool for asking screening questions. So typically not necessarily always in this format, but we always like to understand what their strengths are, what they are interested in, what they think they are good at. We always try and get some information about how things are at school because young people are spending quite a large proportion of their time in school. And so some aspects of how this is going may actually not be known to their families. So obviously, whether they like school or dislike school, I mean, wouldn't be surprised most children would like the half term and certainly not want to attend school in the half term. But actually, are there particular subjects that they find challenging? How are they eating in school? Because unknown to parents, some children actually may not be eating as much as they expect in school. I mean, there could be other curious behaviors. One girl I was speaking to, one of her highlights is to make sure that if she's eating with someone, she always has to be the one who eats the least in a group. And so, such aspects of child's behavior may go completely unnoticed by parents, and they may actually be significantly impactful. Or, of course, though, I mean, we're not kind of focusing this talk on psychological aspects, but certainly anxiety, depression, etc. Some children may confide, with their peers more than they may come back and tell their parents. So it may be that actually a friend of this child knows that they're not really eating as much. Or may have some kind of aspects of what could later be an eating disorder, or maybe suffering with anxiety and depression, but actually clearly they haven't shared this information with anyone, and for many years the parents may have no knowledge of this. Also in school, whether the child's actually participating in sports, etc. So it could well be that there's lots going on in school which the parents don't know. And equally, a large proportion of this is kind of very useful for us when we see child in clinic because what we are not getting is how are some of their symptoms impacting them in school. The next bit is, of course, their home life and who stays at home, how they get on with parents, siblings, whether they find it easy or stressful. For instance, I did a clinic this morning, and kind of fairly, pleasant boy doing well in school and seemed very happy in school and placed chess to a high standard, and was coming with migraines. And on close questioning, he just said that his father has rules for everything. And it was the first time I've heard that he said that actually he doesn't have a problem with school or sports or play chess, but his father has rules for everything. So, I mean, it may not be that the father is kind of wrong in this aspect of having rules, but it could well be that that's impacting on the child. Their activities, their friends, how much they sleep. I mean, obviously, sleep disruption is quite an important aspect in young people. Young people can go through something called teenage sleep phase syndrome, wherein they just can't get to sleep on time. So they may just end up sleeping by midnight, 1 o'clock, 2 o'clock, and then they have to get in time for school. So this is impacting on how much sleep they're having. Of course, things like screen time, social media, uh, then diet, which we alluded to, drugs, alcohol, body image, vaping, all of this being quite important because, as we know, through teenage years, this is where we have two discordant developing systems. So we have what is called the socio-emotional system, which is kind of primarily what's called a limbic system, which means it's activated by impulses, gratification. So you kind of do things which will clearly please you and give you instant gratification. And then, of course, we have the other type of nervous system, which is the cortical nervous system, which is kind of based on logic and reasoning, etc. So through your adolescence, there's a bit of discordance between how these systems are developing. And it's only kind of in your 20s or so that we find that these systems have merge together and are more finely intertwined. Whereas in the young age, it is your socio-emotional system which is more active, and therefore, of course, the context of taking slightly rash or impulsive decisions. And of course, things like drugs, alcohol, vaping, etc., kind of also influence how your emotional as well as autonomic system is behaving. And that can be responsible for also some other conditions like POTS or so that we will discuss later. Emotions such as anxiety and depression, and it's always a good idea to discuss or just ask people from 0 to 10, how would you score yourself in terms of feeling anxious, and the same for feeling low. And you wouldn't be surprised, a lot of young people are quite open with their answers, and they would really give their answers without much hesitation. It's quite useful to just understand whether it is in context of their presenting symptoms or unknown to their presenting symptoms, how they're feeling emotionally. And then, of course, not always necessary, but if in the right scenario, whether there could be any implications of sexual health in terms of whether this context of lower abdominal pain or UTIs, etc. So that's kind of a basic screening history that we take in young people with complex issues. And kind of a large part of this talk is really based on getting some of this information, and that's why information sharing in the right context. So I'll move to the next slide. I mean, you could, ask questions in the chat if you had any. Just going into the context of books. So this is kind of the first book on clinical medicine I read, and it's kind of 150 years old. But I'm not actually going into details about the clinical methods in this, but it's the preface of the book. And this book on clinical methods was written by Sir Robert Hutchison, who's one of the first pediatricians who worked at Great Ormond Street. And what resonates and what I always remember about 30 years after starting pediatrics is the preface, which says, from inability to let well alone, from too much zeal for the new and contempt for what's old, from putting knowledge before wisdom, science before art, and cleverness before common sense, and from treating patients as cases, and from making the cure of the disease more grievous than the endurance of the same. So these principles kind of still continue just going forward, and I'll explain to you why this is important. So this is kind of like the traditional NHS model, which I think is a kind of really good model as kind of it was developed, where uh, the person is primarily seen by their GP, and the GP kind of knows them well enough. And for most common conditions, the young person would go to the GP, who would generally reassure them and say it's all okay. From time to time, you may be referred to a specialist in the hospital, and they might kind of examine you. They probably might not do any tests and just say, well, fine, you're okay, just go back to your GP. And so that's kind of a reasonable model, which I think in its formation is actually a pretty good model. Clearly, times have changed, and so when you go to your GP surgery, you wouldn't see one GP. You'd see different GPs. You'd probably see locum GPs, and then there's of course a lower threshold to getting referred. And when you get referred, you might get referred to different hospitals. You might see different specialists. You might see different doctors in the same specialty. So it may be that though you are seeing quite experienced professionals, there may be that lack of cohesion. It is also possible that as doctors get more specialized, they investigate people more. And actually, they investigate people almost fully and say, well, okay, we've done all the investigations, and oh, you don't have any cardiac problem. It still doesn't answer what the patient's problem is. They say, well, we'll refer you to a neurologist. And then the neurologist does all the investigations and says, well, okay, well, we don't think it's a neurology problem, so we'll discharge you back to the GP. And so the GP receives this letter, which is kind of 3 pages from various professionals. It has kind of all of these tests. And all it then eventually says that, well, we don't think it's a neurology problem or a cardiology problem, so therefore that's good, so you can sort it. But at the end of the day, unfortunately, kind of the child has not really, or the young person has not really got a solution. So, kind of, standard presentation, which kind of I'll go through. So, I mean, I just saw this person last week, a 16-year-old boy with recurrent episodes. And the latest episode was characterized by whole body shaking involving both arms and legs for nearly an hour. He remains aware of his surroundings and can respond to others during these events. Preceding the episodes, he experiences an indescribable sensation in his head, which he calls an aura. And he reports a constant feeling of pressure in his head. And then he complains of not getting enough oxygen, a very fast heart rate, and gets quite panicky. Now, just kind of taking the story, it doesn't sound like an epileptic seizure. And that kind of is a fairly common sense approach, which I think most people who work with young people, whether you're a GP or you're a school nurse, or probably if you're a parent, well, maybe not if you're a parent, and that's why this talk is not for parents, but if you're a school nurse or a GP or any doctor, you probably would say that, okay, well, this may not be an epileptic seizure. You'd be kind of reasonably convinced that this child kind of maybe having a panic episode or maybe something else, but it doesn't seem like an epileptic seizure. But of course, the episode continues, and the child's had several episodes like this, ends up in A&E. any examine him and say, well, of course, if you're complaining of chest pain and palpitations, we'll refer you to a cardiologist. A cardiologist then does a full workup and not just an ECG, but a exercise stress test and a 48-hour tape, and says, well, it's not a cardiology problem. Um, the person confesses to feeling very low, and he says, well, I'm really low. But he is convinced that it's not a psychiatry issue. He doesn't need to see a psychiatrist. He's obviously kind of researched this, and has been on some kind of AI tool, as most young people do. And he's come to the conclusion that he may have raised intracranial pressure. So this is a very common thing, as most of us know now, that it's quite easy to research your symptoms. I think there's kind of nothing wrong in researching your symptoms. And of course, you get these headlines. This is Sunday Times from last Sunday, so it's less than a week old, and you get this headline: "My GP didn't know what was wrong, but ChatGPT did." So a lot of young people would actually research their symptoms. And that's quite common. And in kind of day-to-day consultation, we do actually ask them, have you kind of Googled or have you asked AI? And, what did it come with in terms of what I don't want to do is that if people have questions in their minds, so you don't want them to leave the consultation with those questions unanswered. So I want to ask them, look, if you did have a particular question that you wanted to ask because you had actually consulted ChatGPT, then we can discuss that and we can say whether it's relevant or not, or whether, we need to specifically rule that out. A slight problem is that when people do ask ChatGPT, they actually present their history in that form. So you almost kind of get this history from people who actually have got all their symptoms through ChatGPT, and so it may mean that you end up having to investigate them where you thought it was not necessary. For instance, if someone then has looked up ChatGPT and gives all the symptoms of what you may find in raised intracranial pressure, then there's really no option when you've given all the symptoms to say, well, okay, well, I'll organize an MRI scan, though you don't really think that it's related to raised intracranial pressure, if that makes sense. But ChatGPT doesn't always get it right. And so, I used AI to make all these pictures, really. I just kept giving AI instructions and it kept coming up with pictures. And I often, to explain seizures and syncope, which I'll come to later, I often, compare our circulatory system with our central heating system. So I asked ChatGPT, or actually Copilot in this instance, to make a cartoon of our circulatory system, um, similar to a central heating system. And it came up with this, which obviously doesn't make any sense. So I said, well, this doesn't look good. Try and make it simpler. And then it came with this, which still doesn't look good enough. So the point being that, yes, of course, AI tools are very good, and they could actually give a reasonable understanding in many situations. But in many situations, the history is quite complex, and we may not really get the answers or the resources from a ChatGPT based tool. Just going through episodic movements. So of course, we know seizures are related to electrical disturbances in the brain, and they can happen at any age. And you can have different types of seizures. You could have convulsive episodes where you have jerking of all of your body. You could have episodes where you could just be staring, or just have focal twitching, or just go awakened. I've just put stereotypies in here, which is quite rare, but it's in primary school children, which can sometimes be mistaken for seizures. So they're not tics, but they are rhythmic, repetitive movements, like hand flapping or kind of rocking or head nodding. Um, And they can often start in childhood, and they're very common in children who may also concurrently have other problems such as uh, autistic spectrum disorders. And then, of course, functional neurological disorders, where actually there is no anatomical or structural problem with the brain, but you can have a whole group of conditions where you have weakness or non-epileptic seizures. And again, just going back on our history, this the first 16-year-old boy which I presented, really from the history, sounds like a non-epileptic seizure. And in this situation, kind of the less investigations you could do, the better it is. I mean, it still doesn't mean that you discharge them. You kind of want to still make a treatment plan. But clearly, without doing any investigations, just taking the history, this does sound like a non-epileptic seizure. So, kind of moving slightly forward, clinical features. So this is kind of, again, a ChatGPT, or sorry, Copilot cartoon. Uh, Seizure, syncope, and if you stress for non-epileptic episodes, though some children who have recurrent non-epileptic episodes will deny being stressed. So they may either deny being stressed, or they may genuinely say that they have these episodes even when they may not be stressed at all. Seizure clearly is due to electrical discharges in the brain. Um, a seizure, when people think of seizure, they primarily think of epilepsy, which is of course right, but you could have a seizure because your blood sugar levels drop or your calcium levels drop, or you could have a seizure because you have a bleed in the brain, or you have a concussion, or so on and so forth. But essentially, a seizure is where the nerve cells in the brain discharge abnormal electricity. And seizures can be of different types, as we discussed. They can be generalized seizures, or they can be focal seizures, where you may either just have some staring or some twitching or just involvement of one side of body. Often enough, a seizure has fixed and wide eyes. So during a seizure, the eyes are often open. This kind of a key question that we ask, or if someone's taken a video, we'll always look at the eyes. In a seizure, the eyes are usually kind of wide open. They may be rolled up, or the child might be staring to a side, but often in a seizure, the eyes are open. Almost inadvertently, the eyes are open. Seizures are often very brief, so they aren't as long as some of the non-epileptic episodes. They are a few seconds or a few minutes. Suddenly, unless of course a child has epilepsy, which has been diagnosed, they do not recurrently last longer than 5 minutes. And of course, a child who clearly has the first seizure and doesn't have a seizure plan, you would give first aid, call the ambulance services, and this talk is not primarily to decide how you would manage seizures. So the first aid and the response would be as per your pediatric life support training. Syncope, and we'll go into more detail about syncope later. So syncope essentially is a situation where the brain is not getting enough blood supply. The commonest cause of syncope in children is vasovagal or neurocardiogenic syncope. And as I said, we'll discuss that later. But of course, the most concerning cause of syncope in children is a cardiac event where, for some reason, whether a child has had an arrhythmia or another cardiac episode where the heart hasn't actually pumped blood adequately, and as a consequence of that, the brain's not got enough blood supply, and the child is therefore having symptoms of what would be deemed as a neurological event, where the child passes out or looks very limp or floppy, but the primary issue being cardiac in nature, or the primary issue being one where the brain has no structural issue, but the brain is just not getting as much oxygenated blood as it needs. And then, of course, non-epileptic episodes, which can be longer. Often the eyes are open. The jerking can go on for much longer. It can be quite asymmetric. And of course, there could be a background of stress. Investigations could be normal. And the modern thinking being that these are called functional neurological disorders, where anatomically there's no problem with the brain, but for some reason the software of the brain isn't working as well as it should do, and so it's not sending impulses as it should, or there's overemphasis of pain. There could be sudden weakness. There could be a lot of eye symptoms, like not being able to see clearly. Uh, but functional disorders could have other coexisting symptoms, like a lot of functional abdominal pain. And again, yet again, though this talk is not about abdominal pain, we see a lot of children complain of tummy aches, and they could be older teenagers. And then they have an endoscopy and a colonoscopy and an MRI and a laparoscopy, and everything's fine. And then they said, well, we've done this, and therefore we discharge you back to the GP. But actually, their symptoms don't improve because the abdominal pain could have a functional basis, and that may require a whole different series of management. And parents themselves actually like investigations. No, I'm not generalizing, but they actually like it if the child's had an endoscopy and a colonoscopy and an MRI scan. And so sometimes one does want to actually tell the parents that, look, we think that all of these investigations may not be necessary, because as we discussed, and going back to the Robert Hutchison slide, is that the treatment or the investigation pathway of the condition should actually not be worse than the condition itself. And sometimes doing more investigations is detrimental, because you're almost kind of fostering a cycle that the child themselves think that, well, I've had so many investigations, surely there must be something wrong, and surely no one's finding what's wrong. And they actually do think that more investigations may be necessary, or I might need to see another specialist because no one's really able to come to the root cause of my symptoms. And so we'll just complete this kind of, I think we've discussed most of this. Diagnostic tools, as I said, if one thinks that this is a seizure, then clearly investigations are necessary, though a proportion of children may have the first seizure, never to have a seizure again. In fact, I saw a child today and clearly had a seizure, but had never had a seizure before. And I genuinely feel that this child probably has had just a one-off seizure. Investigations are likely to be normal, and maybe just let's wait and watch before arranging any further investigations, and maybe not do them unless the child has had another seizure. So sometimes one just wants to time the investigations based on the clinical context and suspicion. So going through the functional neurological disorders, the theory is that the structure of the brain is fine, and most of the tests that you would do traditionally will probably come back okay. But it's referred to as a network disorder, where the wiring of the nervous system is intact, but the brain is struggling to send and receive signals correctly, or the brain is over-interpreting pain where there might not be actually a pathology in terms of inflammation, which is causing the pain, but the nervous system is over-interpreting pain. And the strategy for such things, especially the functional neurological disorders, is actually kind of a team-based approach, because what is really important in functional neurological disorders, and of course all the other conditions too, is that everyone involved in the child's health, and whether that's the GP, the specialists, the school, they actually come up with a cohesive plan of action. So they discuss how the child's been in school, how much school is the child missing because of this. Is the child also missing a lot of school because it's also having lots and lots of different hospital appointments during school time and investigations, etc., where actually it may be of benefit to normalize the child's school curriculum, at least kind of get them into school, get them into a routine, as opposed to, as I discussed, not to over investigate them, which means that they are constantly missing school for one hospital appointment, one investigation, or the other. So, especially for functional neurological disorders, a cohesive multidisciplinary approach, as well as an early diagnosis and saying, well, look, um, we don't think more tests are necessary. We think that let's see a psychologist if possible, or let's just have a meeting and decide how we can all come together and help this child. The problem is that often enough, both parents and the child, especially if they're kind of older teenager, do like investigations, and that I'm not saying it's not necessary. I'm just saying that it may sometimes be that the family are getting mixed messages from different professionals. So there's clearly a group of professionals who are wanting to investigate. And it's not wrong medicine, it's just that they're concerned that they may be missing out on something. So they are performing more and more investigations. And they haven't actually thought that this could be functional and that whether more of a supportive management strategy may be of benefit. And that's where sometimes the wisdom from other people can be helpful. For instance, the school teachers who are seeing this child regularly, from their own experience may think, well, okay, well, this doesn't look like an epileptic seizure. So, and they could actually very confidently say that, look, we've seen epilepsy, we've seen seizures, we've seen this child having multiple episodes in school, and we don't really think that this is an epileptic seizure. And that can be quite valuable because sometimes what we get to hear is a child went to school, had a 20-minute epileptic seizure, when actually there's no way to confirm whether the person who witnessed the episode, and therefore I always call them episodes, whether the person who witnessed the episode felt whether this was an epileptic seizure or not. And so this information sharing can sometimes be very useful. Of course, for seizures, and again, as I discussed, we're not going into the acute management plan, but we would say for seizures, if you did have a seizure in school, hopefully the child may have a seizure plan and you just follow the seizure plan. Clearly, if it's the first episode and from basic life support course, if you felt that the child needs to be in hospital, then it's very appropriate to call the emergency services. And of course, it's very important to do some kind of a detailed log and provide it to the parents, who can then provide the log to us, and therefore we have some more reliable information on what the school actually witnessed. As I said, the most important context is a thorough history. Things like EEG, etc., are useful, but sometimes maybe unnecessary, and therefore a good clinical history of the episode is often more powerful than most things. And again, the most important strategy in this, as I said, is a multidisciplinary approach. And you want one person actually to take the lead, whether it's the GP or the pediatrician or someone, another health professional. And it could be a psychologist, but as we know that, in the NHS especially, it's very difficult to actually get into a psychology service in a timely fashion, and so it's often not a psychologist who can lead. But it's very important for there to be a multidisciplinary approach, for everyone to share information, and for then to be a plan which actually is more helpful for the family than everyone being slightly discordant and the child having multiple appointments, but no outcome at the end. As I said, sometimes then the child could be on medications, etc., which actually may not be necessary, and it's almost acting like a placebo. Just going to syncope, as I discussed, so syncope is usually brief, loss of consciousness due to reduced blood flow to the brain, and typically it's followed by a rapid recovery. So it's kind of, you've all seen children get vaccination and pass out and have blood tests and pass out. I mean, of course, sometimes they can be slightly more prolonged. And again, going back to the missed slide, the common cause of syncope in children is what we call a vasovagal syncope or neurocardiogenic syncope. And what essentially happens is that we have two types of nervous system. So the autonomic nervous system, which controls your heart rate, your blood pressure, has two arms. So you have what is called the sympathetic nervous system, which is giving you, the fight or flight response, where your adrenaline goes up, and then for your heart rate goes up, and your blood pressure goes up, and you're all ready to fight because your system's been supercharged. On the other hand, you have the vagus nerve, which does exactly the opposite. So it drops your heart rate, it drops your blood pressure, and you feel very faint and weak. And so in some people, their wiring could be that the vagus nerve gets triggered more easily than it should do. And therefore, whether it's just random or whether it's related to periods when they're not feeling well, or sometimes sad or emotionally upset, the vagus nerve kicks in, their heart rate drops, their blood pressure drops, and they may have what's called pre-syncope. So they may not actually pass out, but they may feel really faint and really weak. And this can happen multiple times in a day. So as I said, the sympathetic nervous system produces your adrenaline, increases your heart rate, increases your blood pressure, and you get ready to fight. The parasympathetic nervous system or the vagus nerve actually does the opposite. It drops your heart rate, drops your blood pressure, and therefore you could just feel very faint and weak, or you could actually pass out. And for some children, unfortunately, this can happen multiple times without clear triggers. I mean, I saw a friend's daughter, she's just turned 18, and she's perfectly fine. They'd gone on a holiday, and her mom decided to, she doesn't do any makeup, and her mom decided to do her eyes and use a pencil to put eyeliner, etc. And obviously, the eyes can be heavily innervated with the vagus nerve. As soon as she touched her eyes, she kind of passed out. And she really crashed in the bathroom, and they got really panicky. And this happened twice in a row. And so then they ended up in the local hospital. And that's classically a syncopal episode where, I mean, the girl does have background anxiety, but, it was on a holiday, it was perfectly fine. They were going out for dinner. Mum was just doing her eyebrows or eyelashes or something to do with the eye. And it's just the pressure of the pencil on the eyelid suddenly triggered the vagus nerve and she passed out. So that's classically a neurocardiogenic syncope, but it can unfortunately happen multiple times. Of course, the more concerning causes of syncope, as we discussed, are the cardiac causes, and therefore anyone with syncope, we would always do a ECG at the very least and just make sure there's no problem with their heart. Uncommon in children are, of course, orthostatic syncopes, which are more common in older people, and then TIAs, etc. And of course, you can also have unexplained syncope where no one really kind of knows the causes of syncope. Just a final slide on POTS before we finish, and then we'll do some questions if people have any. So POTS is called postural orthostatic tachycardia syndrome, and it's quite a curious illness, really. So basically, you have multiple episodes with different symptoms of feeling faint and passing out and nausea and urinary symptoms, tiredness, weakness. A classic finding in POTS is that you have a more than 40 beat increase in your heart rate when you stand up. So from resting or lying down to standing up, your heart rate goes up by more than 40 in children. In adults, it's more than 30. Sometimes we see kind of 35, 37, but usually we take 40 for diagnosis. And POTS happens, I mean, the physiology of POTS, there are kind of three types of condition reasons for POTS, but simplistically, the way our circulatory system works is that heart, as we know, beats actively, and as it contracts, it circulates oxygenated blood to various parts of our body. The way the blood returns is through the veins, but there's no active system for the blood to return back into the heart. So the muscles in your legs and the muscles in your arms have to squeeze the veins, and as the veins get squeezed, then the blood returns to the heart. But the blood can enter the heart from the peripheries only in diastole. So the heart has two phases. It has a systole, where the heart is actively contracting, and as it's contracting, it's sending oxygenated blood um, everywhere. And then you have the diastole, where the heart is relaxing, and as the heart is relaxing, that is when the blood is entering the heart. Now, what happens is that for some reason, and as I said, there could be different types of ports, but for some reason, not enough blood is coming into your heart through the peripheries. Now, that could either be because you're slightly dehydrated. It could either be that the muscles in your veins, for whatever, the muscles in your legs and your arms, for whatever reason, aren't actually squeezing the veins as effectively. Or it could be that just suddenly your sympathetic nervous system, when it finds that there is not enough blood in your heart, just kind of is overactivated and increases your heart rate. So essentially, what happens is that the heart's contracting, is kind of sending blood to the brain, and as you're standing up because of gravity, the brain is above the heart. And so let's say the brain's not just got enough oxygenated blood as much as it needs. So the brain's telling the heart, well, I need more blood. But the heart is not filling adequately with the blood. So the heart is responding, or the circulatory system is responding by increasing the heart rate. As the heart rate increases, because of the increased heart rate, there's less time in a second for the heart to relax because the heart's now contracting even faster. So as there's less time for the heart to relax, even less oxygenated blood is entering the heart. And as less blood is entering the heart is pumping out less blood. And so the brain's still not getting enough oxygen and is still sending cues to say, well, look, I need more blood. And so your heart rate is rapidly going up. As your heart rate's going up, the circulation is ineffective because it's not actually contracting oxygenated blood because it's not filling up properly. And therefore, you have lots of symptoms. The cause of POTS can be variable. I mean, it could be that there could be another condition like hypermobility or Ehlers-Danlos syndrome, which is actually contributing to the POTS. Or you could have a systemic condition like lupus or other autoimmune conditions, or sometimes long COVID-like condition, which is then contributing to POTS. Sometimes you may never just find the condition, and it may just go into a physiology where the child's actually having multiple symptoms through the day, and that just gets so fatigued and tired that yet again one has to actually have a fairly comprehensive multidisciplinary approach, trying to understand what could be the main symptom or cause here, and therefore decide on whether the child needs any medications or not, based on what the primary cause could be. The treatment's always almost like a stepwise approach, where the first step is we ask them to drink enough. Second step is add more salt to the diet. I always ask people to do a sort of exercises, and then of course there are medications. So if we think that they could be dehydrated, we add a medicine called fludrocortisone. If we think it's kind of more related to the heart not being able to contract enough because it's not getting enough blood, we start a medicine which is slightly different, called midodrine. And sometimes, if you think it's actually due to sympathetic overactivity, we dampen the sympathetic nervous system by starting a medicine called clonidine. So that is sports. As I said, kind of lifestyle approach, etc. Yeah, so I think that kind of brings us to the conclusion. I kind of went through it quite quickly. I think most of us like to finish talks early, so I thought, well, finish early. We'll just do some questions. But as I said, what's quite valuable in this neurological type of scenario is a multidisciplinary approach, B, information from school teachers, C, trying to ensure that children actually do spend more time in school, and to try and keep them in school as far as possible. Um, and just, once children get used to not going to school or going to school late or spending only a couple of hours, um, I think it all almost kind of becomes a challenge getting them back to school to spend enough time in school. Um, so we really want people to enjoy school, um, and hope that school's not a trigger for the symptoms. And if it is, then what should be done about that. We also don't want children to be over-investigated unnecessarily. So kind of like a, investigative approach where, well, okay, well, just do all the cardiology tests, or we'll do all the neurology tests, or we'll just do colonoscopies and endoscopies and just make sure there's nothing there. But because that doesn't necessarily always solve the problem. So we kind of want more of a joint up approach where um, we want to make sure that we're doing the right tests, but we're not over-investigating people. So that's the end of the presentation as such. I just wanted to ask if anyone has any questions or anything to ask. You can just kind of either raise your hand or just kind of type them in the chat. Or we could, if everyone's happy, we could, or we could just give 5-10 minutes. But if anyone, I don't really want to discuss any patients who can be identified, because there were lots of people who couldn't attend. So we're gonna, we're recording it, and then I'll just upload it so people could then view it. But if people want to ask specific questions about patients, I just didn't want there to be a lot of identifiable information, if that makes sense. But yeah, any questions, or anyone kind of have any specific queries about either epilepsy or syncope or functional disorders? I mean, I haven't covered, maybe depending on what people think, I haven't covered things like chronic fatigue syndrome in detail, or I haven't covered long COVID. So that sort of requires a different talk. I mean, there's a different set of tests that we do for long COVID and chronic fatigue. And then, of course, I've not covered things like eating disorders, where, of course, if your BMI is quite low, you are definitely going to feel quite faint. So we see a lot of girls, especially who are feeling quite faint all the time, and it's quite apparent that uh, well, there could be a different issue, but there definitely is a context where their BMI is quite low, and that perhaps unless we do something to improve their BMI, their symptoms of pre-syncope or dizziness are just not going to improve. And so, absolutely mandates then a referral to an eating disorder service. And again, for pediatrics or so, we don't do such things, piecemeal. It's best to just get an eating disorder referral through the local tertiary pathways so that, there's kind of a whole package of dietitians, psychologists, etc. And actually, once someone says, look, I think this is probably an eating disorder, and let's just refer you to an eating disorder service, and you do actually the appropriate referral, the child's often seen very quickly. So within 2 weeks, it just takes a very long period of time for someone to actually sit down and say, well, I think, looking at your BMI, looking at your symptoms, I think this could be related to an eating disorder. So it's often very difficult for an eating disorder service to accept a patient unless someone's actually sat down and said, well, this is the history, this is the BMI. And I'm fairly certain that though all the symptoms may not be due to an eating disorder, clearly an eating disorder needs to be excluded. And yet again, as I said, if we actively ask, then we realize that, oh, of course, in school, the child's not been eating at all. And the child themselves may not confess to that, but the school teacher, if they are curious or kind of appropriately inclined, may be able to get this information by watching how much the child's kind of eating at school dinners. And like I said, one of the children I didn't present but discussed briefly, one of her statements eventually, when I spoke to her mum said, well, I asked the school, and then we had a discussion, and she really wants to be in a group, the person who's eaten the least. And this is whether it's at school or whether she goes to a party or it's at home, she has got to be the person who's eaten the least. And it's almost like a challenge. So, yeah. Okay, well, I'll just go through a few questions. I think there's one. Any tips on how to reduce episodes while during exam mock periods with students triggered by anxiety? I think that's a very good question, and every kind of January onwards, and I see a lot of, it's unfortunately more common in girls. A lot of people suddenly passing out, having severe headaches, not being able to complete their mocks, and then that's where the issue starts. The unfortunate problem is that this is often started from way before. And so from way before, the child's kind of been panicking and the child's kind of being quite scared, and actually not much has been done about it. And so it's only when it's kind of reached a crisis where the child's kind of severely kind of anxious about it, that's kind of when parents come in. So primarily, we actually like children to come well in time, because if the child comes much earlier, then the question is whether you could have specific CBT to help in this scenario. When the child actually comes, where the child's actually doing their mocks and is not able to finish the mocks because it's having really severe panic attacks, etc., the session is a bit late. The only thing we can try at that time, because CBT takes actually kind of weeks, or many weeks to actually work effectively. So obviously, you could try things like mindfulness at home or on YouTube or through apps, and you could try something like that, and which most people have already done by the time they come. But then what does work briefly is a beta blocker. So if someone's kind of come just right in the midst of an exam or about to do an exam and they're really panicking, and they haven't kind of had the time to see a psychologist before, and they've already tried some mindfulness apps, etc. The only thing that'll work short term is a beta blocker, and beta blockers work very quickly, and you could help tide over the acute crisis by giving a few months of beta blockers till they've done their exams, and then you kind of want to put a more definitive strategy in place.